Thank you very much. Hello, everyone. My name is Sakiko Kanbara. I'm professor of University of Kochi and founder of EpiNurse and board member of Japan Society of Disaster Nursing. So I work on disaster nursing based on public health and behavioral science and informatics. Today, I would talk about initiative of Japan Society of Disaster Nursing and case study fraud response during pandemic in Japan. This is the map of coronavirus and COVID-19 Japan case by each prefecture. This is Tokyo and Osaka. Big city is really severe affected, and we Japanese we often use the Shinkansen, high rapid express. We use this line like this. So many an urban area is connected by Shinkansen like this. Yeah. First of all, I just introduce the Japan Society of Disaster Nursing Initiative to COVID-19. We launched the COVID-19 the disaster project in May, and we at first we try to visualization of COVID-19 relief as disaster nursing, not emergency nursing or infection control. Then and second, the government secures for the patients, they launch and they prepare the hotel room for not severe case. So we need to dispatch to the hotel to care. So we develop the pre-hospital care guideline. And then for behavior change, especially for a young academic member, develop the self-care note like this. And we put on and we release these items on the WSDN website. Then we held the annual conference in September online, using online and Zoom, and sometimes not only on demand as well as online and synchronized discussion also. And during this conference, they said, the COVID-19 for nurse, it's increasing care task to control by limited manpower and style of work change. Time management is critical, really critical and more difficult. So we have to think about more, not time, but how to concentrate to care or work burden or relationship with another stakeholder or another hospital, something like that. Then everyone we just trying to come into our own lead again Nightingale approach, something like that. By the way, currently I focus on climate change and flood disaster. So in parallel, I try to create the guideline for preparedness of flood at the time of COVID. So, and we have to think about more about the fraud and hygiene at the time of, as well as COVID control. But unfortunately, on July 4th, 2020, the southern prefecture of Japan, particularly Kumamoto and Kagoshima, Kyushu area, experienced record-breaking heavy rain, which caused devastating flood and landslide in many areas of these prefectures. Kumamoto was the prefecture that was hit by the 70 magnitude earthquake in 2016. Then again, flood occurred here. This was the first disaster after the official announcement of COVID-19 pandemic. These words of this slide show the aggravating factor of health risk during flood disaster at the time of COVID-19 pandemic. But we know it's always said likely to happen at the time of disaster in Japan. At evacuation centers, it is too difficult to reveal the infected or non-infected and who is vulnerability people, which need care severely. So, crucial attention should be given to self-protection and care measures first of all. For health security and care, as well as control the infection disease, hygiene is most important, and unpaid caregiver in the family everywhere to secure the health sometimes prevents the emergency. At the same time, we should not forget they are also survivors and who cannot manage the task and workload as important capacity of disaster risk as well as vulnerability. As can be seen above, the hazard map on right estimated the risk area quite accurately. If the resident has adequate risk awareness and if they had taken early action, most of them could have been saved. Creating a hazard map alone is not enough. The core message needs to be communicated more effectively, they said, and the newspaper said, and everyone said. In other hand, this is the same map, but our research data using big data collaborated with Yahoo. One of the facts is that people may become geographically isolated and cannot get to evacuation center. In some cases, although people are somehow able to call for help, it is extremely difficult for a rescue team to get where they are to help them. The map on the slide shows this is pedestrian flow data in a flood-affected area. It shows where people went in evacuation. You can see people gather in place where usually no people are. As responder, we can discuss what is the risk or what is affected area, but we have to discuss about the risk and reduction or mitigation and countermeasure use and as well as control, infection control. It means all hazard approach, but when think more about human health centered, who is survivor, responder, and caretaker or risk taker. Because of pandemic, because of COVID pandemic, yeah, this is one of resident and citizen. They stay outside and have food, take a food and isolate. And this is nursery is own house, not an evacuation center. They have social distancing and have health consultation, something like that. So we should think more who is the community and where is the people who is at risk, rather than where is affected community and second hazard, especially in social distance. We need to connect to secure the health and livelihood. Then, at the time of this decision making on crisis and COVID control, we cannot get the aggregated information and cannot calculate to making reasonable solution. When we were faced on this, the problem before that commander top-down approach often lead individual to make the quick judgment, jump to conclusion, and make the erroneous decision based on bias and cause such as COVID. So, and decision make process is also very important. So we try anyhow emerge the process from big data and record and as well as working group and make sure this is common sense, something like that. This is also one case from disaster nursing collaboration with Nepal. They were trained about epidemiology and health assessment for disaster training. But 1 year after this training, 2019 disaster nursing, the COVID occurred. So they try to adapt this disaster nursing to COVID quarantine and health security. Then one of our colleagues, Miss Parvati Vista, who is the TOT of our team, a focal person of Kathmandu, the public health nurse officer have done continuous and dedicated effort for care as prevention and control of COVID-19. Then she got award in Nepal, Kathmandu, and on a special occasion of Constitution Days. By the way, now WHO 2019, in order to address current emergency risk to public health and the need for effective utilization and management resources, the conceptual frame and paradigm of health emergency and disaster risk management, they call, has been developed to consolidated contemporary approach and practice. Like this. And this is the URL of that. We, disaster nursing, can really understand this meaning, and we have to commit about that. So, at last, we may not have the solution without innovation. As keyword after COVID and DRR and SDGs, we are seeking innovation. We may need normative and cultural innovation which challenges the established value system and social norm, as well as existing cognitive mental frames. According to this typology, regulative, normative, and cultural innovation form the sphere social innovation. We should emphasize social impact caused by change, well-being, inclusion, quality of life, and welfare. In this regard, technological innovation have direct bear on the day-to-day life of the individual as they likely affect people, quality of life, and well-being. So we have to contribute that. So we should think about technical and social and culture as well as control and DRR and human security. Cultural innovation for human security itself also must be designed by disaster nursing, I hope. Thank you very much.